Welcome to the Rehab Links Secrets to Success podcast. I'm Lisa Chase, your host, and today I have a very special guest. I'm been very excited to have him on the podcast, Dr. Stan Longenecker from Jacksonville. Welcome, Stan.
I'm very pleased to be here with you.
This is so much fun because you and I was thinking about, we met, I think, back in like 1996. So we have known each other a very long time. I had just moved to Jacksonville and I was working at St. Vincent's. And you and I met there. You were, board certified orthopedic surgeon, and I had seen several of your patients. And you were doing a clinic, a regular clinic weekly, right? That I started helping with. And that's when you and I really kind of got to know each other and got to work, more closely together. So it is fun to kind of be reunited and to sit and have a chat with you.
It's really good to see you too. And you haven't
Oh,
aged a day.
oh, thank you. I appreciate it. I'm trying, trying to fight the clock. Well, let's just educate our listeners a little bit about our background. I mean, you are obviously an orthopedic surgeon and have worked many, many years treating a variety of orthopedic injuries, but maybe just give our listeners a little bit about your background and what you're currently doing today.
Okay, well, I started out in school as an engineering student and finished up that and went to medical school. And quite frankly, I thought I was going to go into OB/GYN until I had a rotation in orthopedics. And right then and there, I knew that was going to be home.
Ah.
There, I ended up doing a residency. I had to do an internship in general surgery to get into any program. And the United States Navy had paid for some of my schooling, so they put me on a ship for a couple of years. That was a ball. I enjoyed that. Came back to got the Tulane, and again, I graduated from Tulane Engineering. I should have said that. And went on to Tulane Orthopedic Residency. I finished that, and the Navy said, "Yeah, we really need you in Okinawa." So I went over to Okinawa, where I took care of 80,000 Marines and 40,000 Air Force, and I
Wow.
was the only orthopedic surgeon. It was busy.
Oh,
We were
yeah.
we were doing 20, 25 cases on a Wednesday. It was just it was
Wow.
a zoo.
Yeah.
Anyway, finished that and got back and did a fellowship with Jack Houston in Columbus, Georgia. Now, Dr. Houston, Hughston,
Yeah.
was the grandfather of sports medicine. That's really where I was headed. And the clinic that you and I worked in was a sports medicine clinic, and you were the genius behind the back problems that we had. And I always respected you because you could take somebody that was just about ready to get the knife, and you go to work on them, they get well. I learned a lot from that, and I
Oh,
came to respect you tremendously because of that. And I've sent you patients over the years that were friends of mine that were thinking about surgery, and you got them better. And
yep.
maybe now because I'm not as busy as I used to be. Chemotherapy knocked my hands out and my feet out, so I can't operate. And then I'm just seeing patients in the office and
Yeah, it's
trying
tough.
to find good places for them. And my sports medicine clinic kind of morphed a different direction because of my engineering degree. I got involved in implant design and have been fortunate to be on the team of 3 different implants that are tremendously successful. And that bought the farm. At any rate, the farm raises hay in Kentucky now.
Yep.
And so I spent some time up there. I used to be able to fly my plane up there, which was really nice, but I don't trust myself anymore with having gone through what I've gone through. At
Right.
any rate, here we are today. I'm still seeing patients, still doing conservative orthopedic care. Uh, I don't work anywhere near as hard as I used to. And actually, I've morphed into a medical legal business as well. So that's it in
Okay.
a nutshell.
Well, yeah. Well, I always loved, working side by side because we could kind of together collaborate and figure out what was best for the patient. And certainly, when they needed, surgery or other interventions that were outside the, scope of PT, your patients always did fantastic. So I really would like to, there's different listeners that might be tuning in. Some might be therapists, some might be physicians, right? And so I think, you had such great outcomes as a surgeon, and I know your infection rate was far superior, of patients not getting an infection. What was it? 1 in 6,000 versus 1 in 100, that
Well, that's
that
a
happens.
1 in 8,500 total joints.
Yeah,
That's so.
that's incredible. That's incredible because you see, obviously it's so, dangerous and the things that happen with infections. But so I'd like you to kind of talk about how you as an orthopedic surgeon got such great outcomes and mitigated some of those, risks, because I think that is super important. Obviously, getting good outcomes starts with a good surgery and mitigating the different side effects that can happen, like having an infection.
Well, I think the first thing I did was to emulate somebody that didn't have infections. And so it wasn't that I came up with a scheme that was all my own. No, it was a matter of working with a man, Dr. Houston, who didn't have infections.
Mm.
And when you pay attention to his technique, hang on, just a position, my back is talking to me. I paid attention to his technique and how did he prepare that patient for surgery? What did he do in the days before? How did he would actually get the patients a little bit edgy, and for that reason they're keyed up to do a little better than the patient who wasn't ready to go. If you think it in athletic terms, then that was a sports medicine fellowship. When you get a team ready to go on the field, you get them really worked up. Well, you do that with a patient, and they do better. It's a little trick, you get them a little edgy, and they do better in surgery. They do better after surgery. Um, that's part of it. Part of it was the way you prep the skin. That was very important. Using betadine instead of all these other fancy stuff they came out that said would reduce my infection rate, and I never used it because it didn't have an infection rate. Uh,
Ah.
and then it's surgical technique. How do you take that? How do you care for that soft tissue? Do you abuse it like one of my former partners did with a bovie? And he had a tremendously high infection rate because he burned his way in instead of cut. And if you keep your lines clean, you stay in the right planes, the wounds heal so much faster. And surgeons that pay attention to that, they have lower infection rates. Don't be
Wow.
in a hurry. That's another thing. I've seen surgeons get where they just wanted to push, and they have 5-8% infection rates because they're in too big a hurry. And then wound closure is tremendously important. Closing all the layers and not just trying to put 2-layer closures. You get into the knee, you don't realize it, but there's 4 layers of skin you got to close. I mean, 4 layers. And if you pay attention to all that stuff, then one thing happens, your wounds look great because they're real thin. And 2, you don't get infections. You seal that place off. Even if it builds up blood underneath the skin, bacteria don't go through that incision to get to that blood. And people don't understand that. I think one thing that I remember most from Dr. Houston was one day in the operating room. He said, "Have you ever heard a knee suck?" And I kind of drew back and said, "I don't know what you're talking about." So he opened a little hole in the knee and then flexed and extended the knee. After this was while I was closing, and the wound actually sucked. So if you know the wound's going to suck in air, then it's going to suck in bacteria if your skin closure is too loose. So
Mm.
that's really important to pay attention to those kind of things. That's how you keep your infection rate down.
Wow, that's great. And I imagine the scar is so much better as well, right?
Yeah.
When you're working on all those layers versus you're just, hitting just the top couple layers, then those are when, infections obviously and scars are a problem. And I remember I sent you a patient that I had seen because I think the other thing, not necessarily that this has to do with infection, but when it came to total joints, you also took the time to figure out the correct size. And I've had patients that have had the wrong size prosthesis put in the implant, and that became a huge issue. So talk to
And,
that a little bit.
well, I'll talk to you one other point. And one of the knees we designed, 5 of us had been bugging this company for 5 or 6 years, saying there's a difference between men and women. We're having trouble with women complaining about their knees because to get it to fit from front to back, it had to be a little too wide. And if you made it narrow enough, you often notched the femur, and then that had a high risk of fracture. I actually had one girl fractured, um, and that was a disaster. Regardless, we then came up with the concept of a gendered knee. And Christy Mafut studied 800 cadavers, 400 female, 400 male, and created a plot. We found out the women were taller front to back and narrower inside to outside than the males. So that let us create a series of prostheses that fit women better. And all of a sudden, those achy pains that we've been seeing in the women went away.
Mm,
That knee,
interesting, yeah.
that knee paid for the farm. It,
Yeah, but
it,
it's so critical. I mean, and I still see it today, where,
because what happened, the other manufacturers came out with half sizes to try and come up with to try and compete with that.
mm,
Sizes don't work, don't do the job. Not
yeah,
only was the not only was the knee different front to back, but the Q angle, which you know well,
yep,
that I'm not going to try and explain that.
that's
The Q
okay.
angle was greater in the gender knee because the woman's
Right,
pelvis is wider and then it
right.
comes down, narrows in on the knee. That creates a greater angle at the knee.
Yes. So, what would you say to a patient who was looking, or even a therapist who's maybe trying to guide a patient, of what they should be looking for in a surgeon and what maybe questions they should be asking so they make sure A, they find the right surgeon, and two, that they're going to get the right prosthesis and obviously a decrease of risks that happen with surgery.
Well, now I'm going to get one more thing that I didn't mention and why my infection rate was so low. And it's because I was using implants where the bone literally grew into the implant. And that's a living interface.
Yeah.
Uh, we call them bone and growth prostheses, or that's what I call them. But the benefit of that is that wear debris does not penetrate that living interface because it
Mm,
fights back. Cemented interfaces are dead from the day you put them in. So they're good for 20 years and sometimes more. But I just saw a patient yesterday, it's 28 years down the line, it looked brand new. Brand
mm,
new. And
wow. So they
so
last longer.
all you ever have to do if anything goes wrong with the plastic, you just put a new piece of plastic in and you got a brand new knee again. Because it does not get through it does not get through that bone ingrowth surface. And I've got almost 30-year patients now where I see no sign of penetration of the implant.
And then I would imagine that the infection rate is lower too, because that's another place that you see an infection is around the implant, right? And then you got to take the implant out, correct?
No, not with a bone ingrowth knee. You can treat it just like a regular knee, and you can wash it out and close it back up, and most of the time, about 90% of the time, you clear the infection.
Right.
Uh,
But if you don't do that approach,
then you may have to pull the implant.
right,
There's
right.
some studies trying to show that you can do a one-stage train where it's incredible. That's too technical for this discussion.
Okay, so all right, so that I mean obviously yes, having, the type of implant that you're using and how you're putting it, in makes a huge difference. So talk about, what you would recommend to a patient and what they should be kind of looking for in a surgeon and questions that they may want to ask before they, go under the knife.
Don't be afraid to ask them his infection rate. and ask the hospital what his infection rate is, the place he's
Mm,
working. They'll tell you. So the surgeon might get a little upset that you ask him. It wouldn't bother me because I've got a really good answer. Uh,
right.
Ask that. Ask if you're 60 or below, you want to definitely consider a bone and growth implant because women are now living to be 79 average. So you need an implant that'll go that long. And somebody like my wife's probably going to make 100. Seriously, her mama was 102 when she died.
Wow. Yeah.
Yeah.
Well, and then you want that to last. So that's a great point.
Yeah. Now me, I'm not quite sure I'm going to go that far, but I've already had my knee replacement, my hip replacement, my shoulder replacement.
You're the bionic man, man.
They're all bone and growth. I was on the
And so
design
does
team.
that go with the shoulder too? Because I know the shoulder is not as, the outcomes in the past, right? Before like reverse shoulders and maybe this technique, they never did really well. They never got a ton of function out of them, but I have seen that improve over the years.
It has improved dramatically if you use a good implant.
Okay.
If the reverses when they came out solved a huge problem for us because when the patients had a massive rotator cuff tear and arthritis, we had no solution for it until the reverse came out. And the first reverses did not do well because they were cemented and they got loose real quick with a lot of stress on those prostheses.
Mm-hmm.
Um, anyway, once we got the bone and growth on the reverses, it changed the world. They're very, very sound prostheses. And I had to do one he was about 40 when I did him. And I was very cautious in my rehab with that. He comes in at 3 weeks post-op and sticks his arm up in the air like this. And I go, whoa, slow down. He did great. He did great. So they could get real motion, but a lot of it, by the time we get to them, they're older, they've lost a lot of muscle, and it's tough for them to get that back after a surgery.
Yeah, but they definitely do so much better than they used to. I mean, like I said, I remember when you couldn't even get to 90 degrees. You usually got maybe 80. You're lucky if you got 90, but now, yeah, I'm seeing them with a lot better function. So, you know, that's great that the techniques.
I did both his shoulders, and he ended up with full range of motion. He could lift 100 pounds over his head. And
Wow.
then, as a result of that, he wore the plastic out overnight. I ended up having to go back and put new plastic in. He destroyed that, so I ended up putting reverses in. And now he's got full range of motion with his reverse. He was in my office about a month ago for a problem with his hip. But it's just a matter of how, a guy that's in good physical condition when he wears out his shoulder is going to get a lot better outcome.
Yeah, great. And then, so obviously infection rate's important, and then the type of prosthesis and the technique that they're using, right?
Yep.
Is going to be important. And then when it comes to sizing, um, the best questions to ask for that, is it just based on what the surgeon's using?
Yes, I mean, in hips, it's pretty straightforward. Then you want to find out if he's using an anterior approach or posterior approach. If he's doing anteriors and has done a bunch of them, they get well incredibly fast. At 2 to 3 weeks, they're walking without a cane or crutches or anything. I was back after my hip replacement, which, by the way, is an implant that I had total control over the design of. I was in the operating room operating 2 weeks later.
Wow.
Yeah,
That's
and no pain. I
wow.
never had any pain after surgery.
Wow. That's incredible. Wow.
And it's a bone and growth implant.
Right. So that obviously, yeah, that's a big, that's a big deal. Yeah. Okay.
And
So,
it's a matter of how well it fits. We tried to go short a stem as we could. The FDA wouldn't let us go any shorter than 83 millimeters. Oh well, that's what we designed around. And why did I want it short? So my incisions would be smaller and less exposure. The less exposure you have, the less chance of infection.
right. Okay. Does the prosthesis have like like obviously not all physicians are using that particular, right, type of
Correct.
prosthesis. So, is there a particular, I guess, yeah, is there a name or something that they could ask, or is there a database where they can go, hey, these physicians are using?
If you're talking hips, it's Don Joy Orthopedics. Uh, if you're talking knees, it's Zimmer. No, yeah, Zimmer, I'm sorry. But or Total Joint actually is the newest one. We created a new company because Zimmer was messing with us, the design team. So we created a new company, Total Joint Orthopedics, and that we're using all the design principles we used way back. I don't know if you remember this, Lisa. I did a study for Zimmer when we were with them, and I took 70 of my patients, and we took them with a C-arm, moving with the patient as they walked. So you're getting a live data on how that knee's moving. Then we had, as they squatted, we checked it again, and when they knelt on it, we checked it. And what that gave us was the information we needed to change the radius of curvatures in the knee to get the high flex knees that we can see now. And all of a sudden, we're getting 175 degrees flexion. Yeah,
What?
butt on, I mean, heel hitting your butt.
Wow.
So those knees, that information gave us the ability to do a high flex knee.
Wow. That's
Stable
incredible.
mid stance and mid stance. So
Wow.
one of the early high flex designs were unstable in mid stance, and by looking at the range of looking at the data that I left something out of there. Oh, my COVID brain has hit me.
I know.
I was fine after the first COVID round, but the second one nailed me.
Yeah, I know it's tough.
I could flying. Airplanes get too fast for a COVID brain. Uh, the head of engineering up at the University of Tennessee had a program where he took that that dimensional data we sent him and cranked it into 3 dimensions, so you could actually see the knee move as it went through walking and as it went into flexion. Again, that's how we got the data to create the high flex
High
knees.
flex knee. Wow. Yeah, I didn't realize that. That's amazing. I mean, yeah, that's a lot of flexion out of that knee.
Well, immediately other companies got a hold of that knee and copied it. So it was good for about 2-3 years before everybody got a hold of that data.
Right, right. Well, at least maybe now it's more available, but well, yeah, that's really remarkable. Yeah, I always knew you had great outcomes when it came to surgery. So, but we never really like got into some of the details. And I know things have evolved since I've worked that closely with you. So, obviously you do the surgery, and then they oftentimes will either go to rehab, or you'll kind of be involved in that process. So let's talk about, obviously it starts with, no infection, good implant, good technique, and then, the recovery process. So talk a bit about how you get great outcomes and where therapy may play a role in those outcomes.
Well, I don't know if you remember, but the hardest thing I had was slowing the therapist down
Yep.
because they wanted to push my knees hard, and I didn't want them to push hard on those knees because they were bone growth. And if you wiggle them too hard and put too much stress on them, you can loosen the implant right off the get go, and then you got a failure. So I was holding them back from trying to overflex my knees, and yet I still got great outcomes. How did I do that? Because we spent a lot of time with that leg up in the air. We spent a lot of time with ice on it. I strongly encourage people to use uh, ice machines that pump cold water over a pad. So that keeps your swelling down. Well, if you keep your swelling down, then you don't have to fight to get motion. And a patient showed me an interesting trick on total knees, and I used it from that day on. He told me how he got his motions. He lied down flex his hip to 90 degrees and let the weight of gravity pull his foot down.
Yep.
And that would always get a little bit better each day without any pushing.
Yes.
That made all the sense in the world to me. So from that day on, I used that technique, and that really made a difference in patients, how much they hurt. I started getting patients with no pain in the rehab, and I really like that.
That's a
I
great
never,
technique. I use that a lot because to try to do a heel slide and pull it towards you, it just hurts too much. But if you just
yep.
let gravity, take its course, it's more gentle on the knee and it works better. So, yeah,
So you picked that up without me? You figured it out?
I did.
Oh, go girl. That's funny.
Yeah,
That's
that's a great trick, especially when they come in. I'm obviously a cash-based practice, so I don't always see the immediate post-op needs. They'll go have therapy, and then because they know about us, they complement with what we do. And I'll see them, and they'll come in, and they'll be like, oh, I'm pushing my knee, and it's really hurting. And I just adjust just that one thing and use some of the technologies that we have, but that makes a big difference
yep.
for sure. So yeah, so so not
So
pushing.
we've got the surgery down, we've got the implant down, we've got the early post-op, and then you have to have the right therapist.
Yep,
In Jacksonville, I use 5 therapists. That's it. And
yeah,
if I can't get my patient to them, I'm not happy.
yeah.
And nor are my patients, because they'll get someplace else and they just go crazy with them and do all kind of stupid stuff.
Yeah. Yeah, it's very true, I think. And
You want
and for me as a therapist, if I'm working with somebody and I realize, okay, they need to have a surgery, then finding the right surgeon is critical because I've seen that too. Surgery's gone wrong in all sorts of different ways. So I think it's a nice symbiotic relationship, and you and I always had that when I was in, Jacksonville, and then, like you said, you sent several people to me, that were trying to avoid surgery, which is always, a great outcome when we can, avoid that as long as possible. But, having the right therapist and having the right surgeon and, and then working together, I think is critical, having that relationship.
let me just put that one thing out about therapists. When I send somebody to a therapist, I want that therapist to be one-on-one with them. And
Yes.
that's hard to find because they don't make as much money, but they get results.
Yep.
But there are companies that are out there and they'll have one therapist working with 6 and 7 people at a time,
Yep.
and you don't get that TLC that you were looking for when that happens.
Well,
Uh,
and you catch things, right? Just like you said, your preparation, all the things that you do to prepare that patient for surgery and the things that you do during surgery is taking your time, right? And so whether you're doing surgery in a rush or you're taking a history or doing rehab in a rush, that's going to impact, the outcomes. And I feel blessed that I was able to start a practice where, now I can spend that time with patients and not be dictated, by the insurance as to what they're going to pay me for my time or for limiting me from being able to treat the whole person as well.
yep, that's that's hard to find these days.
I know it really is. And yeah, as it is hard to find a surgeon who, is going to be as meticulous as, you have been, in your surgeries for sure.
And
Well,
the other side of that coin is you have to be willing to sit and talk with patients and listen to them.
yes.
You need a surgeon that's going to do that, not be walking out the door as he walked in.
Yes. And that is so hard to find. I hear, and more, not just with surgeons, with any physician, I hear that from patients, and things then get missed or they just get shuffled off to one person or another person because they didn't really take the time to ask the questions, listen. I always say the mysteries in the history. You ask the right question, and the patient will tell you what you need to know.
90% of the time, they'll tell you the diagnosis without you having to examine them.
Yep. That's exactly true. That's what I say all the time. It's just ask the right questions and then your exam just confirms your hypothesis from talking to the patient.
or you just sit back and listen to them.
Yeah.
They'll tell you their story.
Yeah. Absolutely. They want to tell the story, and if you just listen, I think then, they feel cared for and they know that they're in good hands. So,
I don't know what you're seeing, but the new generation of physicians coming out is a different animal. They're number driven. They'd have less tendency to listen. Uh, Drives me crazy because I get people in here that have been misdiagnosed, and all it had to do was listen to that patient talk, and they would have
yeah.
got the correct diagnosis.
Yeah, 100%. And I think that's across the board, physicians, therapists. It's unfortunate. And it's a little scary what's happening, in the medical industry. So, hopefully there's enough of us, out there that can, provide that, that kind of time, so we
Well,
can get the outcomes.
I bet you know the local physicians that you want your patients to go to.
Oh, yeah,
Well,
absolutely.
it's just the same for me. I know the
Yep.
therapists that I want my patients to go to.
That's exactly right. And I work hard to try to, have those relationships and really get to know the physicians that I know get great outcomes. And then if I need to reach out to them, then I'm going to hear from their office. Because that's the other thing. If something does go wrong or you got a question, you want to be able to have that, that line of communication, which, you and I always had, which was great.
And I have with all the people I refer to.
Yeah, which is awesome. Yeah, you need that for sure.
If the surgeon's driving them someplace else, I just pinch my nose and hope it doesn't stink too bad.
Well, is there anything else that that your particular audience, may appreciate? Any other tips or things that you'd like to share?
I'm thinking through, we've kind of gone through a progression here. If somebody walks out of the office within the first 5 minutes, don't think about staying in that surgical office. Think about looking around a little bit.
Yeah. Yeah. And
Uh,
don't be afraid to
they're going
look,
to talk to you the whole time. They're going to do that to you the whole time. You're going to have questions, and they won't be there to answer.
Yeah.
They're going on their way to the next patient. I know one doctor, orthopedic surgeon, that sees 80 patients in one day.
Oof.
80. 80.
Yikes. That's
Ah,
terrible.
there's no time for
No.
that, and he's relying on his mid levels to explain things.
Yeah, and and that I've seen that. And that doesn't, that absolutely does not work for sure.
I know another one. We have a group that's in competition here, and one doctor may have 4 to 5 physician assistants working with him.
Uh,
So you see that physician assistant often the first time.
mm-hmm.
Then the next thing you see is a physician assistant and maybe a different one.
Yep.
And then maybe right before surgery, you see the doctor. I actually had one, what I call terrifying experience, where I'm walking through the holding area, and this patient calls out to me, Dr. Longenecker, Dr. Longenecker. I looked at her and said, "What are you doing here?" "Oh, this doctor's going to do my knee, but I've never met him." I said, "Well,
What?
you made your bed, lady. I'm
Yeah.
not here to help you on that one." Uh, that I'd been carrying her as a patient for 4 or 5 years, conservative management, before she got her total knee. And at the last minute, she switched. I had
Wow.
that happen with an elderly gentleman too, and he ended up with a bad outcome. And he tucked his tail between his legs, came back to me. I figured out what was wrong, fixed it, and he hasn't gone anywhere since. But it's a shame when you see that happen.
It is, but when people show you who they are the first time, believe them. And so I think that's really important. If you go in and you have that kind of experience right from the get-go, a lot of times patients are afraid to question a physician, to go seeking out another opinion. But, if they're not going to give you the time of day on the first visit, or you're not going to actually meet the physician who's doing your surgery and be able to ask them questions, then you got to keep looking.
I think that was good advice.
Yeah, absolutely. Very good advice. Well, this has been super fun. Is there anything else that you would like to share? I mean, these have all been amazing tips and really great information, I think, for any therapist, physician, or patient who's listening.
Well, I think we've covered quite a gamut here.
We sure have.
It sure is good to see you again.
It's so good to see you, and thank you so very much for taking the time. I really appreciate it. And until next time, keep getting great outcomes.
I'm not operating anymore, so I have to rely
Well,
on the people I refer to.
that's okay. You still get great outcomes with your patients because you pay attention, you listen, and then you help find the right surgeon if they do, I'm sure, need surgery. But it does start with listening and doing a good exam and figuring out what it is the patient needs.
Yeah, I'm thinking of this one work comp guy I've got right now. That he is a year out from a major contusion to his knee, and he was shuffled around. They never paid him. Uh, he was literally probably 50% of his strength that he had before, and he thought it was because there was something wrong with his knee. Problem was he wasn't a mover, and movers get well.
Yeah.
You know that,
Yep.
and the ones that dawdle around, they don't get well.
Mm-hmm.
And I finally got him a therapist. He had some time with a therapist, but they did a little this, a little that, and
Right.
didn't really after him to get him moving. Well, it's taken 3.5 months, but we've got him almost back to work. And he was a cripple before.
Yeah, that's a population, the work comp, that unfortunately gets the raw end of the deal, right? Because they just automatically get put into this category of, oh, they're work comp, they're not, they're just trying to ride the system and they just need good care like everybody
Most
else.
most work comp patients want to get back to work.
Yeah,
They need,
absolutely. Absolutely.
so
Yeah, so true.
that's the problem is they have physicians out there that are ready to rubber stamp him. He was actually told that he was off work the day he went, the first time he saw the physician. The next day, the physician put him back to full duty.
Mm,
I don't get it.
I know. I don't either. But, well, again, thank you so much. I appreciate all your time, and I hope that we can talk again soon.
Let me know.